Good morning, everybody. Can you hear me, Barry?
Yeah, you're fine.
Okay, so we've got Andrew's screen sharing there, so he's all ready to go. Andrew's an EP specialist at Sunninghill Hospital. He occasionally graces us with his presence at Mill Park, and he's going to address the issue of when to ablate atrial fibrillation. Thanks very much, Andrew.
So thanks very much, Barry, for the invitation to speak. And it was nice to follow Professor Lord Kaka's talk on the Garfield registry. And you've asked me to talk about when to do atrial fibrillation ablation. And the question really is, when should one think about doing any ablation, particularly atrial fibrillation ablation? And there are only really 4 reasons why one would consider a procedure. That's to improve symptoms or quality of life, prevent or treat tachycardia-induced cardiomyopathy, for a mortality benefit, and specifically with atrial arrhythmias to reduce stroke risk. When do we do it? Well, what do we do? And you can see here a cartoon of the procedure that we do to, in some form or another. And this is a transfemoral vein approach using transeptal approach to the left atrium. And the most commonly used procedure is to go around the pulmonary veins and isolate these from the rest of the left atrium, because the area around the pulmonary veins is the arrhythmogenic focus in the vast majority of cases, particularly in paroxysmal and early in atrial fibrillation. Additionally, some other ablations can be done with roof lines or mitral valve lines, but the initial procedure most frequently is done just going around the pulmonary veins and isolating these. And this can be done using a cryoballoon. And this is an X-ray showing double transeptal puncture with a catheter in the right superior pulmonary vein, which is measuring the electrical signals, and then a balloon which has been inflated in the left superior pulmonary vein. And you can see that venography has been performed and that the balloon is occluding the left superior pulmonary vein, and that balloon is a cryoballoon, and we freeze around that, or we freeze that balloon and isolate the pulmonary vein by damaging that tissue. And you can see here, this is a cartoon on the left, shot from the back, showing a balloon in the left inferior pulmonary vein. And that is what the balloons themselves look like. And that is one approach. The alternative approach is to use what could be nicely termed a branding iron or a radio frequency catheter. And this is an example of one of these catheters on the left. And this is an irrigated tip catheter. It's got holes drilled in it through which we infuse saline to cool the tip of the catheter in order to get radio frequency and heat into the tissue to destroy the tissue around the pulmonary veins, as I've described. How successful is this procedure? And there is lots of discussion about the success and what qualifies as successful this procedure. And the CABANA trial, which was published in the Journal of the American Medical Association in 2019, is probably the largest randomized study looking at radio frequency or ablation of left atrium for the treatment of atrial fibrillation. And there was considerable argument about this trial because the intention to treat trial was in fact showed little or no difference between medical therapy and ablation. But as we know, with lots of these interventional trials, particularly in cardiology, there was significant crossover, particularly to the active arm. And although quality of life was dramatically improved in the intention to treat trial, the mortality benefit was only seen in the on-treatment arm or a reassessment. And at 5 years, 50% of patients having an ablation will still have had atrial fibrillation, and many will have had more than one procedure. And the procedure itself is not without some risk, and we have some way to go in this. And this is just looking at some of the graphs from that trial. And on the left here, you can see that atrial fibrillation as an outcome over 60 months, there was a significant reduction from the blue, which is the drug therapy, to the orange, which is the treatment arm with ablation. And again, with all atrial arrhythmias, again, a significant reduction in the amounts of event in terms of the rhythm itself, and just a different way of looking at it. But again, if you come out here to 60 months, you can see that a significant number of patients in both the drug and the treatment arm continued to have atrial fibrillation, although the burden was significantly reduced from those entering the study. In addition, an analysis of 60,000 patients with atrial fibrillation showed that 1 in 200 patients were likely to die within 30 days of catheter ablation for atrial fib, as can be seen from the study which I've referenced here. And the adverse events in the CABANA study were not insignificant. So the biggest risk, or the most feared risk, is arterial or atrioesophageal fistula, which occurred in 4%, and cardiac tamponade, or 4 patients, 0.4%, and cardiac tamponade in almost 1% of patients, including a significant number of other associated adverse events. And again, the atrioesophageal fistula, this shows various damage in various parts of the esophagus, demonstrated on a CT scan of the chest with a fistula here. And the problem is that you get air embolus, which can be seen demonstrated on the CT scan of the brain on the left. So again, why would we do an atrial fibrillation ablation? And I'm not, contrary to what you may think at this point, averse to atrial fibrillation ablation, but one has to understand the outcomes and the risks associated with it. So to come back again to why we do the ablation. So if one looks at improving symptoms, it has been conclusively shown in multiple studies to reduce the incidence of atrial fibrillation and improve the quality of life compared with antiarrhythmic drugs. And there is absolutely no doubt about that. So symptoms are improved dramatically. That shouldn't surprise one really, because antiarrhythmic drugs, as you well know, are not particularly good at maintaining sinus rhythm. But are there other overriding reasons to do the procedure? If one looks at preventing or treating tachycardia-induced cardiomyopathy, it's been well known for a long time that treating supraventricular arrhythmias which are sustained, including simple things like junctional reentry tachycardias, improves the outcome of patients by reversing any cardiomyopathy which may have occurred. And obviously, in some patients with simple atrial fibrillation, just treating their tachycardia will be associated with an improvement in their ejection fractions and therefore their outcomes. But the Castle atrial fib trial, which was an unblinded randomized trial, looked at symptomatic atrial fibrillation in patients with an ICD for heart failure with reduced ejection fraction. Importantly, with no response or side effects or an unwillingness to take antiarrhythmic drugs. And with a number needed to treat of 6, which is great, they decreased the death rate by 47% and the cardiovascular death rate by 51% in this trial, which had a relatively low complication rate. It's important to remember, though, that atrial fibrillation was still present in 37% of the patients in the ablation arm at 60 months. Although again, this was compared to an antiarrhythmic drug group where 78% still had atrial fibrillation. But similar to the CABANA trial, the actual burden of atrial fibrillation was significantly reduced, and it seems as though the burden is important in the improvement in outcome here. So although clinical trials may be said to have failed because the patients continue to have atrial fibrillation, the importance is that the reduction in burden of atrial fibrillation is associated with improvement in outcome, and one doesn't have to have zero atrial fibrillation. Coming back to the mortality benefit, the CABANA trial on intention to treat did not show any mortality benefit, but an on-treatment analysis suggested that there was a mortality benefit, and a sub-study looking at this suggested that the mortality benefit was present particularly in younger patients, less than 65 years of age. Going to the reduction in stroke risk, the evidence really is mainly from comparative and not randomized trials and registries. And it does suggest that there is a reduction in stroke as atrial fibrillation burden decreases. But this was not really looked at in the CABANA trial, unfortunately. And the guidelines continue to stress that oral anticoagulation in some form or description should be continued even after apparently successful atrial fibrillation ablation, as per whichever guideline for oral anticoagulation you choose to use. And the reality is that atrial fibrillation ablation should not be seen as a cure to atrial fibrillation, but rather as a temporizing procedure. And one should not refer patients for an atrial fibrillation ablation to get off oral anticoagulation. The recent European guideline updates look at a number of the issues that I've discussed here. And as one can see from this graph or slide here, if one has none or minimum signs of structural heart disease, then medical therapy is a 1A indication using dronedarone, which we do not have available, but flecainide or propafenone, and sotalol is a 2B indication, with catheter ablation seen as an alternative in those particularly who do not tolerate or do not want to take medical therapy, and certainly in those who have a recurrence of atrial fibrillation before considering amiodarone. In those with coronary artery disease, a number of those drugs are contraindicated. So locally, with those with preserved ejection fraction, one would be limited to sotalol or amiodarone or catheter ablation. And again, with catheter ablation in the case of recurrence on those therapies. And in heart failure with reduced ejection fraction, heart failure therapy should be initiated, but amiodarone is probably the only drug that is indicated in those with reduced ejection fraction, certainly with a marked reduction, and catheter ablation should be seen as an alternative, and particularly in those recurring on atrial fibrillation. Bearing in mind that rate control with AV node ablation and pacing may be an alternative in a number of the patients with underlying disease. Patient consideration obviously is important as well. And one also has to remember that one wants to improve the outcome for catheter ablation. And if you look on the left, there have been a number of studies looking at improving and in some cases preventing the need for atrial fibrillation, looking at a number of factors, including hypertension, physical inactivity, sleep apnea, alcohol, hyperlipidemia, which Derek will deal with later, smoking, obesity, and hyperglycemia. The problem with all of these is represented in the picture on the right, which shows patients queuing up for pills and surgery rather than lifestyle changes, which are more difficult to undertake. So in conclusion, atrial fibrillation ablation, despite what you may have thought by my initial slides, is a good procedure for symptomatic patients and in patients of a younger age, but can be considered at any age. It should not be seen as a treatment to get patients off oral anticoagulation, and it is a symptomatic and quality of life improver rather than a morbidity improver, except possibly in those of a younger age. Thank you very much for your attention.
Thanks, Andrew, for what I think was a very honest review of a procedure. So I don't see many questions. I'm going to just make one comment. I think the reason you're still in business with transcatheter AF ablations is because the drugs are so terrible. They don't work very well and they're horrible to take. But I'd like to ask you one question. You've got a procedure which requires commonly more than one intervention and works only about half the time. Surgeons can do surgical AF ablations with a more than 90% success rate, and at the same time eliminate the left atrial appendage reproducibly and reduce, if not eliminate, the need for anticoagulation in many patients. Are you sending any patients for surgical procedures, and if not, why not?
I have sent patients for surgical procedures, a limited number admittedly. I think that the surgical data is to some degree I'm afraid to tell you, I think similar to the data from an ablation. If you look at what a lot of people will quote you for atrial fibrillation ablation, or some people will quote you, is a 90% success rate with 1 or 2 procedures. I'm afraid I don't see that, even if you quote that number. And I think that we probably don't refer enough patients to the surgeons, and there is an increasing tendency to do combined procedures with surgeons, doing some of what you do, then confirmed with a transvenous approach to confirming the isolation of the veins and doing a right-sided procedure. So it's probably not done enough, you're right.
Yeah, I think that, okay, I'm going to leave it at that, but I do think that we should look at it more closely, because we don't do isolated pulmonary vein isolations. You know, you do a box lesion in everybody. All right, thank you very much.